Hello, my name is Jennifer Boothia. I am an Army physician, and I've put together a overview of telemedicine. It's targeted for military healthcare providers, healthcare teams, and I am not very skilled at recording videos to upload. I'm also starting to lose my voice just from a lot of conference calls, so hopefully the audio quality is good. The reason I'm doing this is because after 20 years in the Army, a lot of my friends and colleagues are Army and military physicians, and I think that this is an important thing to put out considering the time that we are currently in. A couple of disclosures. So the views that I'm expressing are my own, and I don't represent the views of the Army Medicine Department, Department of the Army, the Defense Health Agency, or the Department of Defense. The slides are my own creation and should not replace any training that is required by your branch of service or military treatment facility. These slides have not been approved by public affairs, and so take that for what it's worth. I have no control over what your facility, IT, or leadership has approved to install or use for the purpose of virtual video visits. I will be discussing the DoD approved platform, specifically Adobe Connect, and I may mention other HIPAA compliant commercial platforms. I don't know, we'll see what I talk about. I'm not endorsing any specific platform, however, for my own financial gain. I'm just here to put the information out. And last, I am doing my best to bring a tool that cuts to the high yield information to begin to utilize virtual video visits. We have a rapidly changing set of regulations and policies surrounding telemedicine. Due to the current COVID pandemic, a lot of these regulations and requirements are changing. So I really encourage you to verify the most up-to-date policy at your local facility level. Some of the information contained is specific to the pandemic and will no longer apply once we are out of that current situation. So please consider this primarily a rapid education tool for the pandemic and not long-term or sustained telemedicine training. Regulations regarding telemedicine are very layered. So you've got federal regulations, state regulations, and then there's DoD and DHA policy that we fall within. So state and DHA regulations can be stricter than federal regulations, and you need to verify what applies to your specific situation. If you do something that breaks the law, that's on you, that's not on me. So a little bit of an outline of what I'm going to talk about. I'm going to do an overview of different telemedicine modalities. This is going to be a relatively brief and a quick and dirty overview. I'm also going to talk about considerations for MTF leadership to broaden telemedicine services and allow healthcare providers to telework in order to continue to support our patient population. I'll do an overview of virtual video visits, an overview of documentation and coding for virtual visits. I will not be specifically discussing asynchronous telemedicine during the course of this video, however. So what is telemedicine? It's the use of electronic communications and software to provide clinical services to patients without an in-person visit. It's also known as virtual visits, and it's a way to bring high-quality healthcare to our patients and to increase access to healthcare and reduce costs. Currently, the use of telemedicine supports the social distancing without complete sacrifice of our access to expert medical advice, clinical assessment, and treatment. Telemedicine and healthcare teleworking supports patient care without adding concerns of potential COVID-19 exposure, and that applies to both exposure on the side of the provider as well as the patients. So some categories of telemedicine. There's synchronous telemedicine, which is generally thought of as real-time, virtual video visits or audio visits, telephone consultations. Asynchronous telemedicine is going to be a store and forward modality. Things such as secure messaging, teleradiology, provider-to-provider asynchronous teleconsultation, and also asynchronous teleconsultations can be used for second opinions or what can be thought of as a professional curbside. A third mode of telemedicine is remote patient monitoring. So it's utilizing a technology platform to monitor patient status. Examples would include something like blood glucose monitoring. I will not be discussing that any further though. A little bit more terminology. So the originating site is the place where the patient is located, and the distant site is where the clinician is located. Audio equals telephone in most circumstances. However, some platforms may be able to just support voice over IP. Audio plus video is then utilizing an audio video platform, or it's utilizing video while at the same time you're on the phone with the patient. And the reason that I mention that is because sometimes the audio connection on a larger platform is a little bit broken or disjointed. And in some instances, you may utilize that platform only for the video component, but then be on the phone with the patient. And that would qualify as an audio plus video virtual visit. Synchronous telemedicine. So there's two overarching models of synchronous telemedicine. You've got a hub and spoke model, and most often that is a healthcare facility to another healthcare facility. It often involves a nurse on the patient side or the originating facility. The encounter can apply to a patient located at a long-term care facility as well. Direct-to-consumer telemedicine is telemedicine to the patient's home or to the patient's location. A few considerations for leaders, military treatment facility leadership, and otherwise. So I really want to encourage people to consider teleworking for clinicians. If providers are using a DoD-approved platform, I want you to encourage the use of telemedicine for clinical encounters. There's nothing specific in regulations that I have found in my own personal research that state that clinicians must be located in a healthcare facility during the course of a virtual video visit. Social distancing should be considered for both patients and healthcare providers. Telemedicine to the patient's home, or as I've already stated, direct to consumer, is an approved mode of conducting virtual visits. DoD-approved platforms, specifically Adobe Connect, utilizes a virtual exam room. Whether the provider sees the patient from their home or an office is not specified in any regulation that I found. Civilian telemedicine platforms allow visits from provider home offices. So I say all that with the bottom line being that you're not breaking federal law by allowing healthcare providers to conduct virtual encounters from their home if they're utilizing an approved platform and are working within the scope of their credentials. Briefly, a business associates agreement comes into terminology when you are a large-scale organization that is conducting virtual health. A BAA, it's a legal document between the healthcare provider and contractor. That healthcare provider, for those of us in the military, generally is going to be the Department of Defense or the Defense Health Agency. And the provider or the organization enters into a BAA contract with the vendor that might be accessing protected health information. Direct employees don't have to sign a BAA if you are part of an organization. It ties to creating electronic PHI using a third-party vendor. And you're required to have a BAA with a third-party vendor, and oftentimes it regards the storage of the electronic PHI and the storage of that data. A BAA must include methods used by the third party to ensure the protection of the data and provisions for regular auditing of the data security. If a provider goes rogue and uses a platform not covered by an organization's BAA, then you open yourself as an individual provider to risk. So bottom line is use the approved platform that your organization has put out. A little bit about synchronous virtual visits. I'll touch upon telephone visits, virtual check-ins, and virtual video visits. So patients to consider for a virtual visit, generally it's going to be lower acuity and ambulatory patients. Things such as routine follow-up or new patient intake can be considered, as well as a virtual video visit for the management of chronic conditions. Consider the use of synchronous virtual visits to support inpatient care without medical providers needing to risk possible exposures. So situations such as having a virtual consult for an inpatient with a nutritionist or with a pharmacist for education are other methods that you might consider. You can also look at the opportunity to utilize a virtual video platform for family discussions on care updates, especially as visitor policies are becoming more and more strict to limit the number of people who potentially could be exposed. Social work counseling is also another avenue for virtual video visits. Inpatient physician specialty consults, so examples could be infectious disease, an endocrinologist, or a wound specialist for management, could potentially be done using virtual video modalities instead of having that provider come in person into the patient's room. So what can be assessed with a virtual video visit? Things like the patient's general appearance, their orientation and alertness, any sort of dysmorphic features. You can also utilize a video to assess their work of breathing. For my pediatric colleagues, you can do developmental assessments. You can look at the skin, and that includes things like the skin tone, but also assessing rashes. Certain ocular issues or oropharyngeal issues may be assessed using a virtual video visit. You can technically observe a patient's respiratory rate, and you can also look at the presence of bruising or visible swelling. So if somebody has something like an ankle sprain, potentially you can do a limited assessment utilizing video only instead of asking that patient to come in for a face-to-face in-person examination. A little bit about vital signs. So obviously, if you're doing a virtual visit to the home, you're going to have some limitations in terms of what vital signs can be recorded. Here are some tips that I find very helpful. So if a patient or family member has a smartwatch, you can use a smartwatch to assess what the current heart rate is. If the patient has a thermometer, I would ask them to obtain a temperature at the start of the visit. You can ask the patient to report to you their current height and weight. Some patients will have blood pressure monitors in their home, and you should ask them just prior to the visit to record their blood pressure. If a patient has a home pulse oximeter, you can also utilize that as well. And as I've already stated, respiratory rate can be observed. So bottom line, do what you can with what you have available on the patient end and document those vital signs as appropriate. So a virtual check-in. Virtual check-ins allow you to talk to your doctor or certain other practitioners, specifically nurse practitioners and physician assistants, using a device like a phone or an audiovisual platform. And it's essentially thought of as a brief check-in, 5 to 10 minutes. Oftentimes it is captured in the context of the patient asking the provider, should I go in? Your doctor or other practitioner can respond, and they can do a virtual check-in by phone using an audio-only visit. They can also do that via secure text messaging or secure emailing and use of a patient portal. Telephone or audio only. So these patient encounters are limited to the use of only being able to talk to the patient or parent. You have a limited ability to assess the patient, in particular if the patient is a pediatric patient. Normal telephone consultations are often patient initiated and for things such as follow-up on labs or medication refills. But we need to think broader and consider the use of audio only for a full encounter. The pros to doing an audio or telephone consult is it's easy to execute, easy to implement. There's no specific patient education or application downloads that are required. Cons, Some types of encounters are better completed with the video component. In addition, coding and billing is time-based if you're only using the telephone or an audio platform, so that lends itself to a lower reimbursement rate. Virtual video encounters are encounters that are conducted totally with video and audio components. It requires the use of some sort of video platform, and it requires the patient to be able to access a video platform on their end, which will require either a smartphone or some sort of an internet connection. It allows a broader variety of virtual visits, given additional elements of video. But you need internet access. You have to take into consideration the bandwidth, because video takes up more bandwidth than just talking to the patient over the phone. It requires longer documentation in a SOAP note format, but has a higher reimbursement rate. A little bit more about documentation and coding, specifically for synchronous visits. So I'm going to talk a little bit about informed consent and protocols. Informed consent is required for military providers to use virtual video visits. However, if you are not a military healthcare provider, generally the regulations regarding informed consent are at the state level. The follow-on slides have some suggested verbiage that you can consider using in your documentation. Documenting in the encounter that the patient was informed of the limitations of using a virtual platform is important, and also that you performed the appropriate checks, specifically making sure that you have verified that this is the right patient that you are speaking with. Also, you would want to document the patient's location, whether the patient is at home. You want to verify the patient's address and also the patient's phone number. Ideally, you would have an SOP for a clinic that would standardize implementation and use. The reason why that's important is because should something occur during the course of that virtual visit, you know where the patient's located and you know the patient's phone number. So let's say the video cuts out. Well, then you can always just pick up the phone and call the patient to complete the visit. What if the patient has some sort of an acute medical issue that occurs? Well, you know exactly where the patient is. So on your end, if you need to contact 911, you know where to direct them in order to rapidly reach the patient. So telephone only, this is verbiage if you are only doing audio virtual visits for the patient. This is verbiage that expands because it applies to a virtual video visit. Other documentation. So you document just as you would for an in-person visit using the SOAP format for video visits. So you want to complete subjective note, objective, and then your assessment and plan. You need to include in your note whether or not you referred the patient for an in-person evaluation, and in particular, if that evaluation is for further testing for a concerning patient that might have been exposed or been infected with COVID-19. You are going to document your objective note to the best of your ability. A little bit more about coding, and I say that this may change in the current COVID-19 situation. It changes already over the course of the last couple of weeks, and so I really encourage folks to stay up to date on what is going on with regards to coding, how to code, and what to code. So there's different coding, whether or not you do telephone only, and those are oftentimes going to be time-based codes. A virtual check-in is coded differently from a virtual video visit, which makes sense because, again, the virtual check-in is essentially 5 to 10 minutes, and it's the patient reaching out to the provider, asking about a specific targeted medical concern. You're going to use standard E&M codes for office visits based on the complexity of the patient if you're doing a virtual video visit. The difference is that you're going to add a modifier that identifies it as a virtual video visit. So if you're doing a hub and spoke model, so hospital to a satellite clinic, for example, you would use the GT modifier. If you're going to do a virtual visit directly to the patient's home, you're going to use the 9-5 modifier. A little bit more about coding, and I found this, and I'm sorry that I don't have the source in order to cite, but this outlines the codes for virtual check-in. It's a G code, and then if you're doing online digital visits, it's going to be a time-based code. Additional coding, and these are specific for video visits, and it encompasses both new patients as well as established patients. The image that I've uploaded discusses just using FaceTime, Skype, and WebEx, but I put a caveat in this slide that this includes all HIPAA compliant platforms used for video visits. Finally, when it comes to coding, please use the link below to find the most up-to-date information during our current pandemic situation on coding guidelines. A few tips and tricks. I've already talked about ways to assess vital signs using a virtual video visit and things that might be on the patient side, but I'm going to discuss a little bit further in the next couple of slides. So how to start? So first and foremost, you want to try to utilize a HIPAA compliant platform before using applications that are not HIPAA compliant. Things such as Skype or FaceTime have been allowed at the HHS level. However, at the level of the state or at DHA level, this may not be the case. If there is a HIPAA compliant platform, we need to be healthcare professionals, which means utilizing the HIPAA compliant platform whenever it is available to us. It's important that you test the platform and you become familiar with the platform before your first patient encounter. Not all of the platforms are necessarily intuitive, and it requires a little bit of practice. Also, I recommend that you practice with mock cases or mock patients using the smartphone. So that way you have a better understanding of what the display looks like, what's required in terms of application downloads on the patient end. I also highly encourage you to integrate your non-clinical staff in the process, because more often than not, they're going to be the ones that are calling the patient to schedule and will be the ones responsible for educating and preparing the patient beforehand. Website manner is something to keep in mind when you're doing a virtual video visit. You want to remain professional and have a professional appearance. The link below is a YouTube video that I think is going to be very helpful to help you get set up, and it outlines some of the specifics or specific considerations in terms of your background, where you actually do it in your home, with regards to privacy and reduction of outside noises such as your cell phone. I think that in the current situation, we really need to take a virtual team approach. So what does that mean? Well, most platforms allow you to assign or designate a co-host in the encounter. A co-host has permissions that are the same as the host. So you could assign a co-host responsibility to your front desk so that they are able to check the patient in and initiate the encounter. You could also make your nurse a co-host, so they are able to allow the patient to come into that virtual exam room and they can do their initial screening before the physician or the PA, nurse practitioner, starts their part of the clinical evaluation. Try out different workflows to see what fits best for your clinic. I can only offer suggestions, but based on the availability of staff, their access to technology, and also what your leadership is recommending, workflows may be different. Virtual team approach can also include multidisciplinary visits. So one of the beauties of utilizing different virtual video platforms that are HIPAA compliant is that you can invite different people into that appointment. That might include inviting another specialist to assist in doing a multidisciplinary visit. You may also bring in a dietitian, a nutritionist, or a pharmacist into that visit as well. You can also utilize these platforms for group education and In some situations, you may find that that's the most effective way to reach your population. So for example, if you have a nurse educator that usually runs a class in person for diabetes education, this would be a way for that nurse educator to reach a classroom size group of patients in order to provide that education. Some suggested virtual workflow considerations. So bandwidth, we're not going to make bandwidth any bigger, any broader anytime soon. So I recommend that you close any applications that you do not need during the visit on your own computer. Patient education should advise the patient to stop any other use of video streaming by other members in the household during the visit. This may be a little bit of a challenge, but it will improve the quality of the visit that you're conducting. Please take into consideration that for some of your patients, they have school-age children or college students that might want to utilize a video platform for education. These are things to consider in terms of what time you see the patient or what factors they need to take into consideration within their home. If you as a clinician are working from home, you would also want to limit other household members using your home Wi-Fi or video while you are doing your own virtual visits. Considerations for setup from home. So if you are able to access your electronic health record system using VPN, that might slow down your video signal, and that then creates a little bit more hassle and headache when you're doing your virtual video visits. So consider using a setup that uses more than one device. And what I mean by that is you take your work laptop and you VPN in to your electronic health record system, and then you use a tablet or other video device that is placed next to that computer in order to actually conduct the video component of your visit. Now, I really want to stress the fact that we should be using a HIPAA compliant application for the video, but this setup may help alleviate some of those lags that you will encounter if everything is being done through VPN. Some considerations for residents and virtual precepting. We don't know how long things are going to exist in our current state, but medical students and residents and I think most institutions have been pulled out of direct patient care. Telemedicine is absolutely a tool that can continue education and training in many of our institutions where you normally would have medical students and residents. Obviously, this doesn't apply to a surgery resident in terms of their surgical skills. However, I want you to think outside of the box, be creative, and figure out ways that you can safely integrate your residents into a virtual video workflow. Residents may be rotating on your service and can connect with their usual patient approval to observe staff conducting a virtual video visit. Just like you would inform the patient beforehand or ask for their permission to have a resident or a medical student in the room, you should use those same rules in a virtual space. You can then have the resident potentially do the initial H&P and visual assessment, and then the resident can text you as a staff member when they're ready to discuss. So again, these are just things for consideration, but consider having that resident after their initial presentation reach you by phone, and then after they have presented the case to you over the phone, then you join the video visit and you do the usual. You clarify any additional history. You are able to assess the patient visually yourself, and then you can discuss with the patient and the resident, all in that virtual exam room, what the plan is and answer any questions. Staff attestation in the electronic health records would still need to be done. You will probably need to do a little bit of modification in your attestation, however. And with that, I'm going to end my presentation. I hope you have found this useful, and hope you're able to potentially find some avenues to conduct virtual healthcare visits to your patient population.